Well, my name is Stan Hudson. I'm an Associate Director at the Center for Health Policy, and it's a pleasure to be in front of you today, and especially to introduce this incredible panel of experts about refugee and immigrant health across Missouri. They're going to tell us a lot today that I think we'll learn a lot and get some good strategies and maybe even some potential points for collaboration. So we're going to start off, and I figured I'd just introduce everybody before they come up instead of doing it all at the very beginning. So we're going to start out with Cathy Anderson. Since 2003, Catherine Anderson has been Manager of Language and Cultural Services at Jewish Vocational Services in Kansas City. It's known as JVS around here. It's a refugee resettlement agency where she manages interpreter services and provides cultural competency and spoken language interpreter training throughout the region. She's a commissioner with the Certification Commission for Healthcare Interpreters. She has worked since 1984 with new immigrants and refugees and has published 2 volumes of poetry that weave together themes of ethnicity, language, work, and culture. She has a master's degree in English and creative writing from Syracuse University. Let's all welcome Cathy Anderson.
Thank you, Stan. It's a delight to be with you here this afternoon, but I'll tell you, it's a little rough going after Dr. Thomas Leviste, so hard shoes to fill there, and I won't pretend to, but I am excited to kind of be part of that discussion because a lot of what I'll talk to you today about is actually those nuances of difference that we see in the immigrant and refugee populations that we work with in Kansas City. First of all, can you hear me okay? I'm never quite sure with microphones. As you know, I'm from JVS, Jewish Vocational Service, and our mission is to strengthen the well-being of individuals, families, community, and the community by promoting successful social, cultural, and economic integration that may be similar to your mission as well. We were started in 1949 with the original mission to resettle refugees coming out of World War II. So those would be Holocaust survivors and other displaced persons from Eastern Europe. And we've kind of, taken back that original mission since '04 when we went back into resettling new refugees that are coming from all over the world through Kansas City, Missouri. So we're the Refugee Resettlement Agency for Kansas City, Missouri. Kansas City, Kansas also has a Refugee Resettlement Agency, and that would be Catholic Charities. So just to kind of get you straight on that, because sometimes people get those mixed up. Our newcomer services include refugee resettlement, refugee social integration, which is really a social work program, refugee employment services, immigration counseling, and my program, language and cultural services. And I'm really delighted, to kind of give you just kind of an insider's view of what it's like to work with such a diverse refugee population within Kansas City. By refugee, I also mean immigrant, too, because once a person is here for a year, they can then apply, as a refugee, they can apply for a legal permanent resident card. And so, it's kind of a semantic difference between an immigrant and a refugee. And I'm going to go a little bit deeper into some of the issues that both groups share. But here's just a look here at all the different nationalities that we're seeing every day. And let me tell you, this is not a finite list. This list will probably be endless. This is just a partial list. And the category that I'm putting all of these under would probably be limited English proficient. They include immigrants, refugees, and what we call secondary migrants, but everybody has the limitation of not really knowing English and having to access services, language services, interpreter services, because they have that need. The secondary migrant is really a term we use in resettlement work, which means somebody who came in as a refugee through another city, perhaps Houston, and then they heard about a job, perhaps, or they knew a family member who was living in Kansas City or St. Louis or somewhere, and they moved there. And they would be what you would call a secondary migrant. And we keep track of that because very often people can receive services even though they're not living in the city in which they were originally resettled, because these are federal benefits. All over the world, we're seeing people, coming across the map. Just to kind of break it down a little bit more, these are the percentages that we saw in fiscal year 2010. So we had 23% of our refugee resettlement population was Somali. You can just kind of read all the way down. The three top groups were Somali, Iraqi, and Burmese. And some of the smaller groups were the Central African Republic, the Congo, Afghanistan, etc. Just to kind of give you, a broad sweep, a broad view. As I said, all of these groups, I'm just going to go back a little bit, have, similar needs. It doesn't really matter whether they're an immigrant or a refugee, because, the language access services are so critical to their health and well-being. We do realize that it's not just the language service, not just interpreting services, but a whole realm of services and approaches that people need in order to thrive and survive, go beyond survival, actually, to thrive within Kansas City. And to do that, we have to understand a little bit of where they're coming from as newcomers. And one major difference is the difference, we call it between collectivism and individualism. So many of our communities are not interested in individuals as much as they are the collective and the whole. Our culture, our typical American culture is very individualistic. Am I right about that? We really promote individual achievement. We stroke it, we encourage it, we certainly support it. An example of that is what happens to a young person when they turn 18. What are they expected to do in the family home? Can somebody tell me? What's the first thing you have to do when you turn 18? In a typical American, whatever that is, typical American. You have to actually leave home, right? And maybe go to college, or get a job. But the idea is that you are no longer, under the aegis of your family anymore. You're almost independent. Now, I was told the other day, in fact, that you can't receive benefits, actually, if you're a child with disabilities over the age of 18. Then the parent has to apply for, legal guardianship, and the whole, status changes. So our culture is really set up to, encourage the individual to leave the home and not be part of, that family roof, that family shelter. Most cultures, especially the ones we see coming into our communities, don't have that paradigm at all. You would never tell a child, to leave home at the age of 18. That's just anathema, that you just wouldn't do that. You want that child to stay at home, help you, as a parent, participate in family life, be part of it. Perhaps the child will leave home at the age of 21, maybe 25, maybe when they get married, or maybe never, but the child is never, ever apart from the family. And that's a very, very different perspective. Also, people have a different view of what we call time. How many of you work in social services with people who speak other languages, or in general? Do people have a hard time making it on time for appointments? They probably do. And the reason they do is that they have a different perspective of time. We kind of stick to what's called agenda time, where we go by the clock. Like right now, I am so conscious of how much time I'm spending talking to you. I'm probably talking too much. But other cultures really believe in finishing one thing before you start another thing. And if that thing they're working on and that they're finishing is related to a family member, then that is going to take a much higher priority than making it to the dentist by 3 p.m. Always, that'll be the case. And, as a social service provider, and as a caring person, you're going to understand that because you're helping people too. And we often talk about that cross-cultural dynamic, that it's always a two-way street. We're seen as a typical American, and, we also see people who need our help. There's a dynamic that happens across cultures. And so what, I always tell people is that they will expect you to understand that they will be late. What you have to do is explain how it all affects everybody else. That person being late will make it difficult for the next person to get a service, or it'll make it difficult for you to provide that service. And because our communities care a lot about the greater good, sometimes, very often, they'll see the whole picture and realize that being late is actually not very helpful to the whole. That's what we hope. And, the difference is that people are usually not late when they have to meet an airline flight, right? That airplane will not wait for them. The judge, in a trial will not wait for them. So people usually know the difference if you explain it to them. We also talk about high context versus low context. A high context language is a language that uses a lot of gestures and facial expressions. For instance, we think of the Romance languages as very often high context. Spanish, French, Italian, high context languages. No, not at all. Japanese, believe it or not, is considered a high context language. And do you know why? It's because of the other kinds of gestures, perhaps the downcast eyes. I've seen a Japanese parent reprimand her child so effectively by just casting down her eyes like that. So it's actually the removal of a gesture is also a sign of a high context language. Now, what would you guess English is? High context or low context? I've told you what. I haven't told you that low context is actually no gestures and minimal expression and just a lot of text. What is English? Yeah, high context or low context? Yeah, that's true. The South and the North. Regionalisms. Oh, the nuance of difference. I forgot. That's right. Here I go, generalizing. Well, for the most part, linguists think of English, American English, as low context. Because, think of what we're doing right now. You're listening to me, but really you're reading what's up there, right? We're paying so much attention to the text. Our language is so text-based. I mean, we have to, read signs, read documents, read all this legal stuff. For newcomers, they are overwhelmed by all that damn paper. I mean, they don't know what to do. All the mail that comes in that they have to, junk mail, and real mail you have to read. It's overwhelming for people. And I always tell folks who work with social services, if you think you've done your job by translation, think again, because that's just the beginning. Many people don't believe something that's translated. Some people do not read in their own language. And other people will read, but they also want the human version, too. They want a person to explain what's going on. So these are very difficult issues we have to overcome. What we're doing at JVS is we've come up with a project that just this year to create DVDs on what a person needs to know in order to go to the hospital. What paperwork they have to take with them, how to get transportation, how to keep track of their symptoms and their medications. So we're just going to put it on a DVD with kind of an interview, like a Charlie Rose session. We're going to have one person interview another. What do I need to go to the hospital? This is what you need. And the two people explain it. And we're going to pass the DVDs out to our, our health centers like Sam Rogers Health Center and Truman Medical Center to help ease that stress of knowing what to do. We also know that direct eye contact, limited eye contact make a big difference. In American culture, I'm trying to look in the eyes of almost every person here because I'm American, that's what I do. But many cultures will not do that. In fact, they think that's disrespectful to look someone else in the eye. And that's something we have to remember because we are talking to somebody and they're not looking at us, we think they're ignoring us. It's not true. They probably are showing respect for us when we're speaking with them. Also, another thing we keep in mind is spatial proxemics, which means that we don't really touch the body in certain places. Certainly with our Burmese and other Asian refugees, we would never touch the top of the head because that's, a sacred spot in terms of Buddhist cultures. We avoid using finger gestures because you never know what you're expressing with your fingers. And so wide motions are actually much, much better. And we're careful about, offering to shake hands, which is so common in this culture. It may not be appropriate in some cultures. Okay, just a real quick primer here on the differences between immigrants and refugees. And this is purely kind of the government description here. By any means. It's not a definition that many of us even would agree with, actually, because it's very limited. But according to the government, Homeland Security, an immigrant is a foreign-born person admitted to reside permanently in the U.S. as a lawful permanent resident, and the status is achieved through family-sponsored immigration, employment-based immigration, or diversity visa lottery. Okay, this is the basic definition of a legal immigrant. And as I told you, a refugee can become a legal immigrant after 1 year. In contrast, a refugee is a person outside the U.S. who seeks protection on the grounds that he or she fears persecution in his or her homeland. In order to obtain that refugee status, a person has to have a well-founded fear of persecution on the basis of their race, their religion, membership in a social group, having a differing political opinion, or even a member of a national origin that's not accepted in the particular country. Also, recently, natural disasters and famine also can describe the category of a refugee. This is all decided at a very high end. The United Nations High Commission of Refugees makes these decisions along with our U.S. State Department. And the reason I'm just kind of telling you this is that very often people wonder how refugees come here and who they are, and what the levels are. So I always kind of just go through this really quickly so you understand the kinds of people that we're seeing every day. The U.S. Department of State designates which countries refugees will be accepted from. The refugee has to fit into a very, very specific category. They're screened by the United Nations Commission for Refugees to determine if they're qualified under international law to be resettled. And then they're also, again, checked by our U.S. Embassy in a host country. For example, if they're a Burmese refugee, the host country would be Thailand. And our State Department would go there and screen everybody, thoroughly vet them. It takes about a year. And guess why they do this? Why do they vet them so carefully? Yeah, absolutely, terrorism. We want to avoid terrorism. So it's all, very, very well controlled. Then, of course, they go through a series of health checks, especially for infectious diseases such as malaria, HIV, and TB. They also screen for physical disabilities, too. So a person, when they come here, pretty much has a dossier of, who they are, where they came from, their national origins, their family relations, and any kind of medical conditions they may have. When they're here, they also have to go through a series of health checks as well, which is where our interpreters are so needed immediately, right then and there. What you may not know about refugees is that they actually have to repay their airline ticket. Okay, when they leave Thailand and they come to Kansas City, for example, they're paying for that airline ticket. Eventually, it's on loan to them, a no-interest loan, but they have to pay it back when, the minute they land. They have to get a job, and they have to figure out a way, to pay it back. So there's a lot of burden on a refugee to really survive once they get here. They're provided some cash assistance and refugee medical assistance, and then that also depends upon certain other factors too, including how quickly they can get a job or not. Usually our refugees are getting jobs within 2 months on the average. We have the highest average in the country in terms of being able to work. Why do they come to Kansas City? Can anyone guess? Why Kansas City, of all places? Refugees come here. We have affordable housing still. It may not seem like it, but relative to the rest of the country, it's fairly affordable. And we do have light manufacturing jobs, kind of entry-level jobs in Kansas City, the casinos, those unfortunate meatpacking plants as well. There are other places that people can work. Just to give you a portrait of a Burmese refugee. Actually, I wish I could quote Dr. Levis, because I think he said some powerful things about generalizations. Here's an example right here. The Burmese communities represent so many different nationalities and so many languages. For instance, the Karen language, which is within the Burmese nationality, 54 different languages of Karen. What's a little bit difficult to understand at first is that Burma, or Myanmar, as it's known also, has 7 states. Each of those 7 states has a separate ethnicity and a separate language, and then within those languages there are all these other sub-languages too. So that's what makes it very complicated. We're getting a lot of Karen speakers into Kansas City, Ska Karen, very specific Karen. And we also have Karenni speakers. We have Chin, Hakka Chin, so they're different different ethnicities and different languages, and it's very difficult to provide the interpreter services at that level because they are so specific. So again, we hear the word Burmese and we think it might be all one thing, the way we think American, all one thing, and we're wrong about that too. There's North and South and East and West, but there you go. You can see how complicated it gets. Here is a group of Somali refugees, Bantu. They are primarily Mai speakers. There are other languages, too, that the Bantu Somalis speak, but we get primarily Mai speakers in Kansas City. Minneapolis, they see other languages. We think there are approximately 12,500 newcomers living in the metropolitan Kansas City area, but we don't know because, of course, the census can't always, determine, exactly who and what those populations are. Our guess comes from just the refugee numbers that we see coming in on a, monthly basis, in addition to the school district, the numbers that they keep, which would be a lot of secondary migrants, and we've just, kept track over the years. I imagine that number is much higher. Yes, Steve probably has a better idea of what the real number is. Just to also this is just kind of a dashboard, just to kind of give you a sense of what we do. We approximately per year, we're doing over 2,000 interpreting, translating sessions. We work with at least 30 languages with a high concentration of 8, which are the most widely spoken languages that include, of course, Arabic and Somali, Spanish, the Burmese languages, Bhutanese, actually Nepali, which is spoken by the Bhutanese ethnicity. We serve hospitals and social service agencies, the schools, courts, and we push for people to get training in bridging the gap because we have a license at JVS to provide the course in Kansas and Western Missouri. Just some ideas in terms of reading, and I know the PowerPoints will be available to you at some point. The Middle of Everywhere by Mary Pfeiffer is a marvelous book. She's the psychologist who's very well known for writing Reviving Ophelia many, many years ago. And she's from Lincoln, Nebraska, is where she lives. And she was a volunteer for refugees living within her community, primarily Sudanese refugees coming from southern Sudan. They were primarily of the Nuer ethnicity. Also, The Geography of Thought by Richard Nesbitt is a marvelous book that just looks at the differences between Asians and Westerners in terms of how they view the world. It's very enlightening. I just want to leave you with this one description of cultural competency, which I think is probably the best. Whenever we say that word cultural competency, people's eyes glaze over because they've heard it. Oh no, again. But we think that this is actually a very warm and open way of describing it. So I'll just read it out loud to you. To be culturally competent doesn't mean you're an authority in the values and beliefs of every culture. What it means is that you hold a deep respect for cultural differences and are eager to learn and are willing to accept that there are many ways of viewing the world. With that note, I will say goodbye. It's been wonderful talking with you. Thank you so much.
Thank you, Cathy. We'll save time for questions at the very end, so we'll keep on moving, so we'll have some time. Our next speaker is Dr. Steve Jeanetta. Dr. Jeanetta joined the MU Community Development Program faculty as a State Extension Specialist for Community Development Process in December of 1998, where he currently serves as coordinator for the Community Development Academy and provides leadership to programs in organizational development and nonprofit management, community and economic planning, and building inclusive communities. And let me take a breath. Steve is a member of the executive committee of the Campbell Center at the University of Missouri, and he's served as an executive director of the Missouri Para Chapter of the Partners of Americas. We work very closely with Steve, so I'm very happy to introduce him. Thank you.
Thanks, Dan. I'm going to talk this afternoon about a project we've been working on with the Center for Health Policy, looking at really how is it that immigrants and newcomers go about accessing health care. We know their experiences vary a lot depending on where they are, where they come from, what their cultural background is. And we also are interested in what is it like for healthcare facilities that are trying to provide services to those groups. We have our research was funded by the Missouri Foundation for Health and the Healthcare Foundation of Greater Kansas City, and we were looking at 3 immigrant groups in the Kansas City area, a Latino community down in near Monette, it's called Cassville, and another set of immigrant groups in St. Louis, and then an African American group down in the Boot Hill area. So far, we've collected our data and have analyzed the Kansas City group and the group down in Monette. So we'll talk a little bit about some of the themes we identified in that work that seem to cut across a little bit their experiences, but how they kind of manifest themselves in each of these places is very different. So we're looking at trying to find out what maybe some of the barriers are facing refugees, immigrants, as they access healthcare services. What you find out too is that when you look at these things, we make this assumption sometimes that there is an actual healthcare system, but at the local level, it's not really a system, and it varies depending on where you are. If you're in a city like Kansas City, if you're in a certain neighborhood, your healthcare system might be a clinic, it might be a hospital, it might be some combination of some of these things, and where you migrate within the place really affects how you access those services. A lot of newcomers don't really know how to make that work for them. And in rural communities, it could be, there might be a hospital in town, there might be a clinic in town, but they're not typically full-service hospitals or clinics, and so you might go in and get diagnosed for something, but you might have to go someplace else to have a baby, you might have to go someplace else to get your dental care, and so you can find yourselves in rural places seeking basic healthcare services really in a broad variety of areas. And so we wanted to understand a little bit of what those experiences were like, and then identify a little bit how they're dealing with that. What are some of the strategies they've put in play to kind of make some of those things work for them? The findings so far kind of include our interviews with newcomers in the Kansas City area. We had 15 interviews. We worked with Cathy's agency to conduct some of those interviews. And then a group of 11 Latino immigrants living in the Cassville-Monette area. What we did was we put together kind of an interview guide around some questions to kind of guide a conversation. So what are some of the positive things your experiences were like? What were some of the things that happened that worked pretty well for you? And then there were a set of questions around, well, what are some of the challenges that you faced when you were doing that? And then the third set of questions was really kind of what are your perceptions on your health in your community, and what are some of the ideas that you have about how some of that might be addressed? We gave them each a gift card, about $10 gift card, I believe it was, for participating. And then the interviews were conducted in the native languages, and they're translated, and then the translation was transcribed. And so we were working with, like in Kansas City, we were working with JVS, and they have their translators are mostly for medical translation, and they're not interviewers. So we wanted people to feel as comfortable as we could. So we basically trained them in how to do the interview, and so they conducted the interviews, and then they translated the interviews orally and to a recording, and then we had that transcribed, and then we used a content analysis to kind of take a look at what they were saying as it related to what we were kind of looking for. So in Kansas City, the three language groups that we were looking at was Arabic, Somali, and Hispanic, and they came from Iraq, Sudan, Somalia, Mexico, Cuba, Colombia, and Ecuador. And Cassville was pretty much a Latino community, and the people that we interviewed were from Mexico and Guatemala. And you can see in the Kansas City group that we had pretty diverse range of ages, anywhere from 18 and 65 and over. In Cassville-Monette, the immigrants are pretty young there, and it's a fairly new group, and the oldest was in their 40s, and mostly women in both groups. And in Kansas City, we had a diversity. Most were married, but some were single, divorced, or widows. And in Cassville, they were all either married or single. And most, you can tell that the household sizes were pretty large. And in Kansas City, we had a wide range of education, but they're actually a pretty well-educated group. And then in Cassville, most were completed secondary education, but almost half completed just primary education. Or most completed just primary education, but 4 did complete high school, or that equivalent. So what we want to do is find out what some of the positive, negative, and what some of their ideas were about what would be helpful. So some of the things that worked pretty well for them in terms of how they access care were, they told a lot of stories about, when they were talking about positive experience, that included somebody helping them. They didn't do it alone. So if they went to a hospital and, like in this particular case, it was a woman that she was in a shelter, and a shelter facilitated her access into the hospital, took care of her while she was there, And then when she left, it was kind of she was kind of guided all the way through the process. She then later follows up, going back to the same facility 2 months later on her own, and it was a completely different experience for her. And so the idea that there's somebody that helps you connect to the resources and navigate the system and get into where you need to go and understand what the services you're trying to access is real important. Interpretation, that makes a lot of sense. But they talked about interpreters when they go into the building. If you're going into a hospital, this came up quite a bit in the Kansas City. You go into this big hospital, where do you go? How do you find out somebody that can actually talk to you? And it scares a lot of people away. But also the relationship with the doctors. But then the one that's the real challenge is understanding the bill at the end and having somebody that can explain to them in their own language what they're paying for and how they're paying for it and what the costs are and some of those kinds of things. It's a real challenge to folks. And so when they have those kinds of supports, they were happy to describe them. Another thing was this availability of medical information. This was more an issue in the Kansas City area. In the Monad area, in the more rural area, they thought education would be nice, but they didn't really have any sense of what that might look like for them. And the transportation. And in the city, it's more about transportation to and from facilities. In Monad, it's about figuring out which town I got to go to get service, how do I get to that service, how do I get back, how do I get around in that community while I'm there. And so there's some different kinds of complications. Transportation is important in both contexts. Affordable services. This is mostly, they're talking about having insurance, but it's also being able to feel like that before they go in, they need to think that they're going to be able to pay for whatever it is they receive, or they're just not going to go. And that was the case in Monad in particular. They talked about going to one clinic, I think it's an FQHC, where they felt comfortable going, but there were a limited number of services they could get there. And so when they had to go someplace else, they were very, very leery of making that transition because they just didn't feel safe doing that. So when they talked about the affordable services, they knew when they went there that they were likely to be able to afford, at least in a short or a period of time they could connect with, they would be able to pay for it. But they had all kinds of stories about going to places and having bills where there was just no way they were ever going to have that kind of money to pay for it. And so you see a lot of fear emerging in terms of the cost of health care that they just won't go because they feel like it's going to be too expensive for them. And that fear is, unless it's an absolute emergency, they're just not likely to go. And availability of payment options. And this came up in both communities. In the city, there was really kind of a lot of confusion around what was available and how it was. But when they felt like there was a plan that they could put in place, and they could make $50 or $100 a month payment that they were comfortable with, then it eased a lot of their concerns about paying for their health care, which I think in turn would impact their ability to seek it in the future. And then good communication and non-communication, or good communication with medical and non-medical staff. In this one, there was one doctor in this community that a lot of the patients kind of gravitated towards, and they trusted her, and they could describe and articulate what it was about her that made it a good experience for them. And usually they did that when they were also describing, why it was horrible going someplace else. And one of the things you run into in rural communities in particular is if you get dependent on one or two practitioners, and it becomes really difficult for the community if they move on or if they get sick or they go on vacation, and some of those kinds of things make it really difficult to get sustained and care, and that makes it difficult then to facilitate trust in that local system that you need in order to be able to provide quality care over time. And then understanding the instructions on how to take medications and those kinds of things, that came up a lot in Kansas City. It didn't come up as much in the rural area, and I think part of that was because most of the people we talked to were really more oriented towards, I just don't want anything to do with the healthcare system if I can avoid it. It's too scary, it's too complicated, it's too expensive. And so there were a few people that would talk a little bit about the issues as they saw them in terms of understanding what to do, how to take care. In Monette, where they did talk about this, was really more in the sense of who do I talk to, or how do I talk to somebody that can help me understand what it is I'm supposed to follow up with. And there really weren't many examples of that, so that's probably why we didn't hear much of it. And then trust in the healthcare provider. When they trusted them, then the experience was much better. So really, kind of the key research question is, what are the specific factors that facilitate trust? And some of the things they mentioned there, was taking time for them, talking to them, explaining to them what some of the things were that they were dealing with, and a lot of it is culturally different than what our practice is used to dealing with. And so because it creates a challenge in terms of, okay, so how do we meet the needs of this population group when we don't have a lot of the linguistic resources they need, and our systems aren't set up in a way that they can connect with real easily. And then some of the factors that contribute to some of the negative experiences. And the idea of a lack of a connection with somebody who can guide them through the system. I had one woman in the Monette area ended up going nearly 60 miles to deliver a baby because she knew that's where her insurance could be used, but didn't know that there was another facility only 10 miles away in another small community that did. Just the lack of understanding of what was available to them in that particular area. And we only interviewed 11 people in that community, and they mentioned at least 8 other places outside of their own community where they would be referred to for if you're going to have a baby, you can go up to Monette. If you need dental care, you can go to Joplin, or you can go to Rogers, depending on where your insurance is. And so they talked a little bit about all these different places that they get sent and referred to by family members, by the people they see in the clinics, by a lot of different things. And so this idea of not having any place you can go to get information about how you manage your own health care is a real challenge. Interpretation. In Kansas City, a lot of it was focused on quality of interpretation, when you get interpreters, either at the beginning of it, with your healthcare provider, at the end of it. In Monette, it was like, interpreters? Where do we get an interpreter? It was really hit or miss with that. And so they would be largely were grateful if they had anybody that could speak any other language when they went in for services. And so the one clinic where a lot of the folks went had regular staff and those kinds of things that they needed. But some of the other places they would have to go for follow-up kinds of things just didn't. And so a lot of times they just wouldn't go because it wasn't, they didn't feel like they could get it. And one woman talked about going to a hospital and seeing a cousin of hers there. He and his wife were filling out paperwork that was written in English. Neither one of them spoke any English, but they were filling it out kind of like they knew what they were doing, and they were just completely lost. And that kind of thing, I think, is not that unusual. And it's those kinds of stories perpetuate within some of these networks that they have. They have very tight networks in their communities. And so certain services are discouraged and other services are encouraged, even though they may not necessarily get the kinds of treatments they need in the places they feel the most comfortable going. And transportation services. Getting around a city can be a real challenge, but also in the rural areas there are no transportation services that you might be able to get to and from your local clinic or your local hospital, but in some places you can get transportation to other cities, but not always on a regular basis and not always when you need it. And so it's complicated by not always knowing where you need to go too. If you need to go to Joplin from Cassville or Monette, that's a pretty good trip. If you want to go to Monette from Cassville, it's 15 miles. That's still a pretty good trip if you don't have transportation. And so where you go, the idea of travel and transportation are pretty well interrelated there. And then in the city, it has to do a lot more with available transportation systems when people need them and getting them back and forth to and from appointments and those kinds of things. Lack of medical information in the native language that came up a lot in the Kansas City area, not so much in Monette. A lot of it, they say, yeah, it'd be nice to have education, but they really didn't have a sense of what that meant or what it would look like. This idea of lack of health care insurance, and also the limitations of healthcare service, the insurance puts on where you can get services. In the city, it means which hospitals you can go to or which clinics you can get into or what kind of services you can access. In the rural area, it might mean which town you have to go to get the services you need, and whether or not you can get services. Let's see, difficulty accessing, long wait times. This came up in the Kansas City area a lot. We talked to 15 people, and 1, 2, 3, 4, 5, 6, 7. Yeah, 7 people put time numbers to their waits. All of them talked about long waits, but one said 11 hours, 10 plus, 6 with a bunch of kids, 12 hours, more than 15 hours, and twice people said 10 hours. That's a long time to wait anywhere. I was thinking, well, in 10 hours you could put somebody on a bus from Kansas City, send them to St. Louis and back if you wanted to. But the idea that there's a real long wait is a real discouraging. And part of that is caused by their orientation towards emergency rooms, and being that's where they came from. A lot of them, that's the first place you go, and that's how you access the system. And actually, a number of immigrant groups, I think, have their systems are set up that way. And so, but a lot of the emergency rooms aren't even integrated into their hospitals. So they're operated very separately from the hospitals that are sometimes housed in. And so there's a real disconnect between the emergency rooms and actually accessing the health care in those facilities. And so it's a real difficult situation. And the other is there doesn't seem to be a lot of sharing of responsibility for those amongst the healthcare providers in those regions. So a lot of the folks that don't have insurance, that don't have or have limited insurance, they all go to kind of the same places, and so they tend to be overwhelmed with the cases. And then in talking, we did some interviews with some of the doctors too, and they talked about, well, in their clinics and stuff where they come in for appointments, we can arrange for them to have translation. But when they show up in the emergency room, you don't know what kind of translation you're going to need and what that's going to mean for you on any given day. And so some of the wait can often be facilitated simply by not having people there that can help them access the service. And so then there's lack of trust in the providers, payment options, and all those kinds of things really confound the situation and make trust more difficult. So, and the cost is a real big deterrent, and it's causing a lot of people to just not seek it. And so it isn't necessarily the cost per se, it's their belief in the cost. It's their perception of the cost. If I go see a doctor, it might cost me $50, it might cost me $5,000, $25,000, I don't know. But they all have stories of people that gone to, to have a checkup and then come out with a huge bill, and it scares off everybody in their own little networks. And so you have this real fear of the cost of healthcare as a major deterrent their actually even seeking health care, especially in some of the smaller communities. And then in those that have insurance, the fear of losing insurance, how you can use it. Like some undocumented people have insurance, but they can't actually use it. And so there's a number of those kinds of things that that really affect the outcome. And so we see people, they're basically they're telling us they're not going, or they're stopping, or they might get a treatment but then not do follow-up because of the cost of seeking the treatment or doing that. There's a real high fear of getting sick and not being able to get taken care of. And so when they talked about being healthy, it was about food, and almost always healthy food or whatever their native foods were, which sometimes they can't get in the communities they live in. And then also this idea that the ER is the only place you can get services. And what they said that would be helpful to them. Payment options in the hospitals. And I think understandable ones, so almost like a billing system, like saying, if you come here, this is what it's going to cost and what you're going to have to pay, and here how you can pay it. Trained interpreters, flexibility in timing of medical tests, especially when they don't have multiple tests in one visit, so that helps with the long waits. Some support groups, particularly in the cities that we're talking about, disease-based support groups. So if you, around some issues that tend to be prevalent in certain communities, like diabetes, and sometimes in the Latino community, and then providers educated on cultural differences. Not so much as much the medical staff as some of the other support staff and others in the hospitals. A lot of the stories they talked about as being the more difficult ones were with the reception people, or sometimes the nurses or others in the hospital that weren't as well trained. And then flexibility, availability of healthcare services in the evenings and weekends that came up in Kansas City. And then support to help them find and access services in the community. So setting up relationships with groups in the communities that can help them facilitate the access they need. You could see in the best experiences were those that people had through the various support systems in the community, like a Central Latino here in Columbia, or Casa de Salud in St. Louis, or a pretty well-informed family network. But, a lot of the newcomer groups, a lot of the immigrant groups just don't have those same resources available to them that most of the rest of us do. And it really helped make a really complicated system easier for us to manage. Thanks.
Thanks, Steve. Our next presentation is going to be done by a collaborative team, so I'll introduce them both before we get started. Let me get this presentation up real quick here. Here it is. All right, it's going to be done by Dr. Campbell and Samantha Marquard from St. Louis University. Samantha began working with the New Americans in the fall of 2004 through the Center for Survivors of Torture and War Trauma Youth Program. Since then, she has led classrooms, taught health classes, organized after-school programming, done home health, and provided family practice services for this population, and continues to do so today. She has also given many lectures for SLU and other community agencies on the wonders and challenges of working with New Americans in today's healthcare climate. She is married to the #1 barista in the region and has a 2-year-old son and 6-month-old daughter that keep her challenged daily. Dr. Campbell is a native of St. Louis and graduate of St. Louis University School of Medicine. He served 7.5 years of service in the U.S. Navy Medical Corps and did a stint as resident program director at the University of Alabama Birmingham School of Medicine. He returned to St. Louis to found the Family Medicine Residency Program at Deaconess Hospital. In 2000, he founded the Institute of Family Medicine, which is a nonprofit that reaches out to provide primary health care services to otherwise underserved populations. Through the Institute, Dr. Campbell oversees medical services at the International Institute, the International Welcome School, which is a clinic dedicated to patients of Vietnamese heritage, and a Head Start program who serves a largely refugee population. He also previously directed La Clinica, a clinic dedicated to Hispanic patients. Dr. Campbell and his wife, Veronica, have been married for 38 years and have 3 children and 3 grandchildren. And I'll start with Dr. Campbell.
Thanks. I appreciate the opportunity to come and talk with you today and tell you a little bit about what we're doing in St. Louis. when I spoke with Nancy originally when she was setting the program up, and she asked me to come do this, I said I wanted to do, and I like your term, the collegial team or collaborative team, that's what it was. Bring one of my colleagues, Samantha Marquard, because she really has, on a day-to-day basis, doing the work in the trenches on the programs that we have through the Institute. So a little bit about the Institute. As he said, it's a 501c3, and our mission is reducing barriers to quality primary health care services for vulnerable children, families, and elderly. Our services aren't limited to this population that we're talking about today in terms of new Americans, immigrants, and refugees. But they are all under the category of vulnerable children, families, and adults. And what makes it unique is that we're taking we're setting up small and cost-effective clinics in neighborhoods and sometimes inside the walls of other social service organizations to provide convenient, quality health care services in a trusted, that word's come up a few times this afternoon, and culturally sensitive environment. So this is our work with the new arrival, but I just want to mention a few other. We go, for example, on campus to the Evangelical Children's Home, which is now called Every Child's Hope. And some of these organizations here that we're working with in terms of the new arrivals and refugees and immigrants are really sort of prototypical of what the organization does. So, for example, the school-based health center at the Youth in Need Head Start, that not necessarily because it's Head Start, but because it's located in South City, very near the International Institute. And so it has tended to cater and gear up from a staffing perspective for taking care of non-English speaking families. But as a Head Start, they also were not only have required, like other preschools, to check the box that a child has had a physical or had their immunizations. They have to actually assist the families in getting them and get them established with the medical home. And so we agreed to work with them, and they provide the space, and we actually set up a clinic. Samantha's the provider there, and go in and take care of that. So it's an example of some of the collegial kinds of relationships that we have in order to make this all work. It's also a good example because the next question is, well, how do you pay for all that? How do you make that work? And that's piecing things together as well. So, for example, at that facility, we're keeping our costs down. Youth in Need is providing the space. Samantha is also faculty at the St. Louis University. It's a great population for the nursing students to work with, so we are compensated somewhat by St. Louis U for taking students in as a training site. And then we also will bill insurance when that's on the table. The adult vaccine program at the International Institute, just a quick example there. They came to us because no other provider wanted to come there and provide the vaccines. Their solution was, we'll send the patients down to our facility. So you have 25 people a week who don't speak English, who are new to the area and don't know their way around, would have to obtain an interpreter to go, and they're all in one place on Tuesday morning, and all the interpreters are in one place on Tuesday morning. So our solution to that is we take our vaccines and we go there on Tuesday morning. So that's how we got the program at the International Institute. And the Vietnamese population, now they're not exactly new arrivals. Most of the patients in our Vietnamese clinic are actually probably came over in the 70s. We were approached by Catholic Charities that they had this elder population that they were sort of helping and assisting and case managing and navigating, I guess was the term used earlier. But they didn't have a place to go for their medical care. They had been going to an office and it closed. They had tried some other places, the FQHCs, and there was even some Vietnamese doctors in South St. Louis, and they just weren't finding a place they were comfortable with. And so this is another example of how different organizations come together to make this work. We actually hold our Vietnamese clinic in the Youth in Need Head Start office. The Catholic Charity sends over the case manager and interpreter, and so we're able to provide the care by just basically sort of covering the costs associated with the time that the providers spend there. So that's a real quick, rough overview. The one thing I wanted to sort of summarize what I feel like it is that we do is that we're taking primary care health services into the community and providing them to patients within the patient's social context. And that's sort of, whether it's Evangelical Children's Home or Youth in Need or wherever, that summarizes the work of the Institute for Family Medicine. So at that point, I'm going to turn it over for practical wisdom to my colleague, Samantha Marquard. Oh. All right.
I know we're getting low on time, and I'm the closer. I don't do a lot of sports stuff, but that's a thing, right? Okay. So, like everybody has said, there is a lot involved with working with new Americans. And this lecture is adapted from some lectures I've done for undergraduate students who maybe have not worked with new Americans at all. So some of this knowledge will be kind of low level for you, and I'll just breeze through it. But the slides are nice, and I thought you would enjoy looking at them. So I think we've learned a lot today, and I'll start with my quick tidbits. I always like to have, the things if you forget and you glaze over because it's been a long day, this is what you should take home. Number one I took out because we're talking about new Americans technically, but I always like to remind people that culture is not always just where you're from. And I think a lot of times we come into talks like this and we talk about, oh, well, they're from, Afghanistan, or I'm from Arkansas, so that means she's from Arkansas and all Arkansans are the same. So remember that we all hold our own cultures inside of who we are, and we've talked a lot about shared experiences. And so I'm an Arkansan that's also an Army brat that has lived in St. Louis longer than anywhere else. So I'm, have a lot of cultures. Remember that your patient is your best resource for learning about his or her culture. I have a lot of manuals in my office on cultural competency and culture in healthcare and the healthcare beliefs of the Romas or the whatever, population. Everybody's different, and you need to talk to the patient or your client if you're not a healthcare provider. It's number three, I guess. It's easy to use cultural differences as the reason for a patient's behavior. That's not always the case. Sometimes it's not because they're from so-and-so. Maybe the reason they're behaving the way they are has nothing to do with the fact that they're from Afghanistan. I think medical providers are very nervous about upsetting someone or traipsing on some new, oh, well, their culture is different than mine. So they did something that I maybe don't want them to do, and I'm just going to let it be that way because it's probably because of their culture. I mean, people are willing to adapt and learn and come to a new place, and they want to have a good relationship with us, and so it's a matter of finding that common ground. Don't just completely deny it because it's probably because of their culture. And then finally, despite being from a different culture, patients are still patients. I teach each one of my new students this. I think it's the most important thing. Patients have universal needs for compassion, understanding, healing, regardless of where they're from, regardless of how old they are. We all share those universal needs. You have them, and so do our patients. And so I think if you always go into working in a new environment that makes you uncomfortable, remembering that about people, you'll get really far and have really good relationships. This is a very busy slide. It's specifically towards my students that I work with. But it says, know your context, okay? So these are some of the large refugee populations that are coming into St. Louis at the time. It's a little bit outdated now. I've got Burundi, Burmese, Bhutanese, Eritrean, Iraqi, Cubans. Those were our big groups in like 2009, 2010. So things have changed a little bit, but those are still our big groups. And I always reference the CIA World Book. I think if anybody knows that website, it's the best place to go because it's the most trusted information if you're just wanting to know what's going on in the country that your patient is coming from. It will give you basic literacy levels. It gives you things that are going on with wars in their country, religious persecution. So I always send my students there first, and then I say, now talk to the patient. But this was kind of what was going on at the time. So challenges, because we all are always looking for challenges and then how to fix them, right? So we talked a lot about interpreter services being a problem. In St. Louis, again, we are a very large refugee resettlement city, and St. Louis City itself is very small in comparison to other cities. And so we've got a very highly concentrated population. We have a lot of these nations that have very, very obscure dialects, Burmese being one of them that we deal with a lot. Eritrean has a number of dialects as well. For instance, our Kunama interpreter, there's one for St. Louis Metro, and he works a regular 8 to 5 job, so he's available from 5 p.m. to 8 a.m. I mean, that's great if you wind up in the ER, which is usually, at 2 a.m., but for those regular doctor's appointments, you're making a phone call conversation, which can happen, but isn't ideal, right? Number 2 challenge, clients from newer countries maybe have not yet experienced Western medicine. And so they're new to, like we've talked about, following schedules, coming at the same time. My office, I always tell people, I work by myself most of the time. It's just me. There's no, receptionist or nurse or a medical assistant or anything. And I handle organized chaos very well. Like, that does not stress me out at all. I live in organized chaos at my house. It's just how it is. And my patients appreciate that because they kind of handle organized chaos very well. They usually have 3 or 4 kids. They maybe brought their husband. They've got the kids they're watching, from down the street. And that's all fine. But that's not true in most Western medicine clinics, right? I mean, everybody would look at them like they had 8 heads if they brought in 6 babies with them, like 2 from down the street that they were just watching today and their niece. And that makes everybody crazy. It doesn't make me crazy, but I'm not the norm. With that. How to use pharmacies. I have the director of ESL for St. Louis Public Schools. She's lived here a long time. She's a highly educated woman. Loves to tell the story of the first time, she's from Egypt, the first time that her son came to St. Louis, or the first time since she came to St. Louis, her son had a fever. She walked into Walgreens. She had no idea what she was looking for. She's like, I know what the fever medicine's called in Egypt. I have no idea what it is here. And it's not because the woman was uneducated. She just didn't know how to use Walgreens. Medication regimens. Those involve time. We've talked about people have different time-space continuums, and if we want people to take time, like, very strict, and then, they're not used to that, we need to work around their schedule, whatever it may be. And incorporating into that medication regimen situation things like Ramadan and fasting, and what do you do with that, okay? Challenges. Many clients have not seen a doctor for years. This is true in our Vietnamese clinic. On my intake appointment, my first appointment, I'll say, well, when's the last time you saw a doctor? Oh, when I had my baby. Well, how old is your baby? It's an elders clinic. She's 37, so I always laugh. And so because of that, if they've never been to a doctor or have not been to a doctor in a very, very long time, we have a lot of complicated needs we're dealing with: chronic, acute, psychiatric. They may come in because they hurt their toe, but they haven't seen a doctor in 37 years. That's probably not the only thing they got going on. Then the context from when the patients come runs deep into their health problems. I love to talk about one of my Vietnamese elders that is adamant that the reason that he has hypertension is because he was in a prison camp when he was 19 years old. He absolutely says that medicine will not fix it. The reason that he has this problem is because when he was 19, he was in a prison camp. That's a big challenge on a lot of levels. Is it because he was in a prison camp? Maybe. There's plenty of research to say that stress does those things to patients. But also, we may be able to help that with hypertensive medicine, and we need to find that spot. But every time he comes in to see me, we have to talk about it. Him and his wife together, we talk about it. And then I always tell people this: simply the new environment can make people sick. Those of you that have lived in other countries have different plants, you have different foods. You come to the United States and hot Cheetos are a thing. And you've never had hot Cheetos before. Those give you some reflux, right? I mean, that gives heartburn. Flowers are going to make you sneeze that you've never been around before. And I deal with this a lot at the International Welcome School, because that school is specifically for kids who have just moved here within the last few months. And the first fall and the first spring are a nightmare in that place. I think all I do is give out Claritin. It's just the new environment. This is just an example of a picture schedule. I do a lot of drawing. A lot of my cultures are places that that don't have, maybe they're not literate in their own language, their language may not be written at all, or the folks are working, like I said, on schedules that, are not your typical schedule. So maybe at sunrise, when we're doing our prayers in the morning, we do these two things. When we're doing our noontime prayers, we do this pill. And I'll draw the pill, I'll put the number on it, we'll color it, whatever it takes for people to understand it. I always apologize, I'm not an artist, I'm a medical professional, so my kidneys are not the prettiest kidneys in the world, but we get the point across through our drawings, right? So that's just an example of an idea of something that, that's something you have to do when you're working with new Americans. We have to bend, move out of our norm. Let's see, I think I had written another big challenge that I thought of today while these folks were talking. She was explaining the difference in refugees and immigrants. Something that I've had to learn now is that our refugees have services. Our immigrants are not eligible for services for many years. So you're dealing with that situation. They can't get, government health care, things like that. And then finally, my last challenge before I move on to Joyce is that interpreters, even when you find a great one, maybe isn't somebody that the patient trusts. I deal a lot with a tribal situation, or even like my Bosnian interpreter at my old job would not. She was adamant she was not going to help with the Roma families, which are the gypsy families, right? So it was so out of her comfort zone. And our Somali families maybe are coming from two very opposing tribes. Burmese families with many, many states, and they've had different experiences, and they don't want to help each other out. They're mad, and it's a struggle. So the trusted thing is big. Okay, finally the joys. So I think that these patients brought in my definition of patient care every day, because when we are in the medical schooling, we're learning this is how you care for a patient, that you're going to fix them, they're going to feel so happy and proud because their doctor helped them, and they're going to love you forever. Well, that's true, but I think I forget that it's not just medicine, because I don't do a lot. Many of my days I spend writing out schedules and calling kids' schools because mom doesn't know how to call them. Those things are things that healthcare professionals can do, and I think a lot of times we just forget that we're willing. Refugee and immigrant health is laid back. I always like to say that because there are plenty of people that have spent a lot of time in our traditional healthcare system and are tired of it. So you can always think, well, maybe I need to go to refugee and immigrant health. We can chill out. It's chaos. It's good there. I always say the patients feed you and dress up for you and feed you some more. I used to do home health. I was a community health educator, and I would schedule my day on what patient was going, because different patients fed me different food. My Bosnian families, it was always coffee and some kind of dessert, so that was probably good around 3 when I needed a little pick-me-up. My African families always had some kind of fish, so scheduled that around lunchtime. That's how I scheduled my day. And my Vietnamese patients, while I was pregnant with my son, I didn't think they were going to stop feeding me. So it's fun. Simple treatments are often new and significant treatments for clients who've not seen a provider for a long time or ever. We think it's another person with diabetes. I got to think of their 97th diabetes med. We've maxed out on everything. Not these folks. A lot of times they just need, Flonase for the first time or some Neosporin. There are things that they have never had access to. And you can kind of take a step back from all this high-tech medicine that's just exhausting. And then finally, to lead into that, your mind is stretched to think outside of the normal American healthcare tridium. And I like to tell the story of just a few months ago. Well, the first day of the welcome school, one of the teachers came in and she said to me, "I need you to see my student." And I said, "Okay, that's why I'm here." And she said, "I'm pretty sure she has leprosy." And I was like, "Well, what makes you think that? I'm pretty sure she probably doesn't." And she said, "No, I lived in I was in the Peace Corps and I lived on this tiny island, and we had a leper colony there, and this student looks just like those folks, and I think she has leprosy." And I'm thinking, well, crap, I don't know anything about leprosy. They don't teach that in the United States. So I called him, and he says, on Marcus Welby, there was an episode where there was a big lesion, and if you touched it and it hurt, it was not leprosy. And I'm like, okay, well, that seems good, because I was just going to Google it. So the girl comes in, and I'm thinking, I don't know what I'm going to do with the leprosy girl. And she says, I said, well, does it hurt? And she said, oh, it hurts so bad. And I was like, yes, it's not leprosy. I don't know what it is, but it's not leprosy, because Marcus Welby said so. So it just, it's different. It's not diabetes. I mean, I had a kid a month ago that had bubonic plague 2 weeks before he set foot in my office. 2 weeks. I had to call the CDC. I didn't know what I was supposed to do with that. He'd been treated, but so it's just different, and it's nice, I guess. It's, I don't know. I like it. But I think that's it. I think, the time is up, and you guys are supposed to go home, and I'll leave it at that.
We do actually have a few minutes for questions, so if we have any questions for the panel, does anyone right now? Oh, yeah. I've got a question for you guys if no one else does, because, you were talking a little bit about how, there would be dismissals of patient behavior due to cultural beliefs, and I know I was in the mental health session earlier, and they were talking about some dismissals of physical symptoms due to mental conditions and things, and so I was wondering, and you mentioned like the refugee health check that they take place. Are there any like mental health screenings, or how does mental health add to some of those challenges that you face in treating and providing services to immigrants and refugees? Yes.
To answer, Samantha, you probably would.
I think it's a big component. Before I worked as a nurse practitioner, I worked at a place called the Center for Survivors of Torture and War Trauma. It works specifically with people who have experienced trauma or torture from war. And I think, just as I spoke of the man who believes that his hypertension comes from being in a prison camp, I think there is a lot of stress and a lot of mental health added, that's from these patients' histories. Whether it's just extreme poverty, it may not be true war or torture experience, but there's a lot of background, and that background is weighing on the families and the shoulders, and there is a lot of depression, and it's very talked about, and it's very undiagnosed. And a lot of the cultures are very anti-talking about it. I mean, I deal with that challenge a lot with our Vietnamese clinic. They don't want to talk about it. I'll bring it up, like, I think your dad's depressed, and I think we need to talk about it. But no, I think he just needs to have more Ensure, or, he needs to eat more. That's it. So I think mental health is a huge part of these patients, and it's a challenge because not only do they have a huge mental health history, but the services are very limited in that department, especially once their refugee benefits run out.
Also, you've probably heard of this aspect. People tend to have physical symptoms that are probably traced back to, mental health issues. And so it makes it very difficult to figure out what's going on. And it's not, that they're hypochondriacs or anything. They really do have these symptoms, but often they'll be, like headaches or nausea, that kind of thing. And people won't at all identify it as a mental health issue. There's so much stigma about it. And the language, the words are not there, to really describe it. And so people are at loss for that, too.
Languages that do not have
the word, yes, for mental.
Depression or mental illness.
I have time for probably one more question. Any other questions? Oh, there, Nancy. Okay. Hold on.
Hi, I work for the Department of Health and Senior Services in the Health Statistics Unit, and we occasionally get questions, and actually just had one maybe about a month ago, where people call in and are trying to get data on immigrant or refugee groups. And I know that in the first lady that presented that you had an estimate of how many, and so we were just wondering if you had any advice on where people could go to get this data, because you're right, it's something that Census doesn't get good numbers on, or else they don't. There may not be enough people for them to release it due to confidentiality concerns. And so I know you mentioned that the schools keep some records, and that's usually like the last lady that called was wanting to do an intervention with children, of immigrant children or refugee children. And so we suggested that they contact the schools to see if the schools were tracking that. Are there other sources that we could refer people to where they could, if they're trying to do some sort of intervention, I mean, should they go through some of the organizations like you've mentioned, or what would be the best course of action for people like that?
Yeah, I'm sure Steve would have some ideas on that too, but my first guess is always the refugee resettlement organization in the particular city and the school district. That would be my guess. I'm always wondering that question also.
Yeah, I think the schools data is probably going to be your best estimate for that. You may not actually be able to get it from the school. You might have to get it from DESE or like somebody that consolidates that data, like OCDA, the Office of Social and Economic Data Analysis here at the MU campus, collects a lot of that data. They do a lot of polling and survey work and other kinds of data collection for DESE.
Follow-up, the estimate that you provided, ma'am, was that just for the population that have been in the U.S. within a year, or was that the total number regardless?
1,500?
Yeah.
That's actually cumulative. So that would be what, not, from one year to the next.
Okay.
That's, over a number of years, like present, what the population would be currently. So.
Hi, I just have a quick question. My name is Miriam, and I work for the university here in town, at the University in Columbia. And my question is, you mentioned that you work with people with war trauma, and I'm thinking that happens to everyone in that country. So what is your experience with working with people, refugees and immigrants who are educated, who know English or another language? And I know that here we focused on people who do not speak English, so they need interpreters, they need help. But what is your experience with these people coming to the country?
I think that's a really interesting question and a good one. What I found, even at the Welcome School, which is specifically for new American children, last year we had a woman who brought her children there because she thought it would be the safest place for them to be for their first year. But she was here on a Fulbright scholarship from WashU. I mean, the woman was more educated than I am. She was inventing, fake cartilage. So, and her student, their experience is not the same as a true refugee, I guess you could say. But that doesn't mean that they don't need assistance and that they don't have a history. I know in St. Louis we have a great group that works with women who have experienced domestic violence, but are specifically from groups like some of the Eastern European conflicts that the families have been here longer and also are much more educated. And those conflicts, I think, are there's more intricate, details to that. And there are services, but there are not many. And I think that is a very under-addressed group of people, and I think it's good that you brought it up.
Well, I just think there's a certain image of a refugee people have in mind, like a photo that you put on the screen is people who work in meat packing industries, people who don't speak the language, and I think that's not always the case.
No, that's a good point.
Well, thank you. I think that's about all the time we have for this panel. Let's give them a round of applause for the great information they provided.